All right, everyone. I think we've got a really good quorum already. Thank you all for coming back for day 2 of the Social Determinants of Health workshop. We've got yesterday was packed. I think today is equally packed, if not more, based on the number of speakers that we have that they're going to be sharing their wisdom with us over the course of today. So maybe just quickly to kind of set the table. So let's think back briefly on yesterday and kind of what the plan is for today and how it connects into tomorrow. So yesterday, we heard from a lot of Indiana-specific experts around Indiana-specific use cases. We started by having the team from Regan Street talk about the Indiana Addictions Data Commons, and talking a lot about what they're doing to connect clinical data with non-clinical data, specifically social determinants of data, determinants of health data, and talked a lot about kind of what's coming next. I know in particular some of the discussions around like the self-service portal and things like that are things I know I'm really looking forward to. So it's good to hear kind of around what's happening in that space. And then we had our friends come in from FSSA to talk about 211 and Indiana Community Connect, which is a resource directory and referral management system that's powered by the data from 211. Connor Norwood also joined that panel to talk about some of the improvements that they're making from a data governance perspective and improving data sharing from FSSA out to community organizations. So it was helpful to hear that update as well. Then we pivoted to having a panel of folks from CHIP Indy, IHIE, and MPH talk about the data exchange pilot that they were executing to link data from HMIS, Medicaid, and the INPC, and make the data available to all 3 of those partners, as well as a pilot payer and provider. And then we rounded out the Indiana section by having Karen Comer speak about the Cortico plus Savvy solution that they're building, talking about how they're connecting community data assets, at the zip code level, geocoding it to the INPC. So a lot of great information from the Indiana kind of roundabout, if you will. And then we invited Carol Lewis from Kaiser to come in and offer an external perspective to continue to expand our horizons as to what's possible. And she talked a lot about universal social health screenings and talked about like the specific kind of screening questions that they were focusing on, from the prepare system, but really kind of honing in on financial security and housing and food and transportation. And one thing that she really zoned in on that I thought was really interesting was around the establishment of a member panel to help and support uptake, to talk about how to drive engagement, including how to integrate some of this work into their overall kind of day-to-day workflows. So a lot of really great information that came through from Kara from Kaiser as well. So now today we're going to continue our learning tour, and we're going to kick it off by having Christine, and I'll introduce Christine just in a moment, kind of speak to us from what's happening over the Camden Coalition. And then we're going to have 2 broader panels. The first one is around governance, that it's governance, ethical and legal challenges, kind of combined. One of the things I saw a lot in the questions yesterday was just around data sharing and accessibility. And I know there's some questions regarding, how access to some data from like DWD came from, and, things like that, which I think it's helpful to kind of use this panel to kind of be able to dive into some of those challenges to be able to figure out, if we can't remove the roadblocks, it's hard to kind of look ahead as to what's next. So there'll be a good opportunity to kind of start breaking through some of those. And then we're going to have a second panel that's going to be diving deeper into the resource directories and the information and referral systems that power them. Yesterday, we heard about Indiana Community Connect. This will be an opportunity to learn further about some of the other kind of resource directories that are available, such as those 3 in Bertha. So with that in mind, we're going to continue our learning today. We're going to take all of this information, and then we're going to feed that into 3 work groups that we're going to have tomorrow, focused around state, local, and these resource directory types of challenges. And so really use today to continue to ask the questions that you have, to be able to kind of zero in some of the key challenges, so we can kind of walk into tomorrow and really kind of start creating those plans. So I'll take a quick pause, see if anyone has any questions regarding the plan for today and how it leads into tomorrow? Hearing and maybe seeing none. Let me check. Yes, seeing none. Let me introduce our wonderful guest speaker.
Hey, Darshan, real quick, just a quick note, and I'll put another note in the chat just to get us started for those who weren't able to join on day one. I know this kind of loads the chat a little bit, but I'll try at the end to wait to add in Christine's resources that she had shared with Waldo. But if everyone could just, put your name, organization, and kind of who you represent, again, that would be probably helpful for those who maybe weren't able to join us yesterday, just so that we can all kind of get to know each other virtually. This is really, we know, challenging when we have so many on the call, but we really appreciate everyone joining us again for day two. So.
Excellent. Thank you, Emily. Appreciate that. All right. So I'm going to take a moment to introduce Christine McBride. Christine is a manager of the Health Information Exchange for the Camden Coalition of Healthcare Providers. In 2015, Christine joined the Camden Coalition to offer training and project support for HIE enhancements and features. And during her tenure, the HIE has doubled its size from a user-based standpoint and from a list of service offering perspective. Christine oversees efforts to enhance HIE's functionality, develop customized tools for HIE participants, improve data quality, and collaborate with community partners, all of which I think zero in exactly on what we're doing here today and tomorrow, right? And her experience working closely with medical and social service providers has shown her the value of using data to improve patient outcomes while navigating the healthcare system. And I will say, Christine shared some of her slides in advance, and in parsing through them quickly, I'm really, really excited to kind of hear what she has to say and kind of continue to kind of offer some more context. So with that, Christine, the floor is yours, and thank you so much for joining us.
Thank you for having me. Hi, everyone. That was a great, quick introduction to me and what I'm hoping to talk about today. And I'm, thrilled to be here and share some of the things that Camden Coalition has been doing. I can share my screen so I can walk through the PowerPoint that was mentioned. So let me just do that and put that into presentation mode. Great. And so, yeah, today what I was hoping to do is just really give an overview of how we think about governance at the Camden Coalition as it relates to community-based organizations and health information exchanges. And first, what I wanted to focus on is really just a quick overview of the Camden Coalition of Healthcare Providers, because as an HIE and kind of in my work, we do a lot more than that, and all of the work complements one another. So on our screen is our vision statements. We're working towards a transforming health systems to improve the well-being of individuals with complex health and social needs. So the Camden Coalition started a little over 20 years ago. Our founder actually was a provider in Camden, New Jersey, and primarily serving Medicaid patients in primary care, and was about to go out of business as a doctor and sort of grappling with this idea of why is it so expensive to serve the patients with the most needs? And from there, we were born into the Camden Coalition because it became this larger community of providers all saying, what can we do to actually change the system to better serve these patients? You may have heard of us in the sense of the cost curve. So we kind of were looking at this idea of population health and trying to understand where the most costs were, allocated towards, and looking at things like 10% of patients, 74% of receipts going towards those patients, and sort of, again, this idea of how do all of these systems interplay with one another, knowing that there were poor health outcomes for patients in this group, but also just across the country, kind of in any sort of space. And so we started thinking as an organization about how do we think about cost? How do we think about utilization? How do we think about what are the actual things that patients need? And from there, we really started to understand, okay, the actual healthcare system itself isn't really serving patients. And then this is where we really evolved into our current work. So I'll pause here for a little bit longer just to really kind of overview the ways in which the Camden Coalition as an organization has grown into. I'll first mention that we are really in the space of care management and clinical redesign. One of the things that we realized, 20 years ago was that, again, patients weren't getting the care that they needed. And so we now have two teams, one that is focused directly on care coordination with patients. So it's a group of amazing social workers, nurses, community health workers, a medical legal partnership actually to help really just navigate all of these really tough systems that put up barriers to patients actually improving their own health outcomes. And then on the flip side of that, the clinical redesign team where I sit is really just thinking about what do providers and systems need in primary care, in behavioral health, in the maternal health space to really pilot different programs that may work better than the traditional models. How can we help them design these programs? How can we use the IHIE to build tools and not just rely on their traditional electronic medical records? How do we use data and analytics to help them understand what are some trends within their patient populations? And so all of those things really work together as we think about what are some things that an office might need extra support on. One really successful program that we ran was called the 7-Day Pledge, in which we were receiving a list from Medicaid of anyone who's living in a city of Camden who had Medicaid, and they were attributed to a primary care provider. And we set up real-time alerts in our HIE to within every hour to alert that office if one of their patients had been admitted to a hospital. And then they took a pledge as part of the 7-Day Pledge to contact and schedule an appointment for those patients within their primary care office within 7 days. And then we use data to do a monthly look back to understand who are the patients you couldn't reach, why couldn't you reach them, and not so much in a punitive kind of way, but in a sense of like, what are other barriers these patients are struggling with that make them unable to get to your office? And we had so many really interesting learnings and success there. And this is a resource I would be happy to share out after this presentation, but just really, really rich learnings about what are all the things that we can do and at what point do we hit a barrier to say like something from a policy perspective has to change. And that's really where the coalition building comes into play. So we have a legal and advocacy team that oversees a lot of our regional convening within Southern New Jersey, actually going to the state and advocating for different policy changes. One really successful one was around medical transportation, where the state had chosen a vendor that was very unreliable, was often not picking up patients for appointments, not picking up patients when they needed to get home from their appointments. And their system of just kind of scheduling was so outdated that we helped advocate for making improvements there and holding them to higher standards so they could improve the services they were giving to their patients. And so that's the kind of work we're doing in our region of South Jersey. And then at the state level, and then finally, we also host what's called the National Center for Complex Health and Social Needs. And I'll end my presentation with this because I think this is a really interesting one for this group, considering, the majority of you, I think, are from the Indiana area. So in terms of kind of working with us, this National Center has been a really great mechanism for us to share learnings that we're seeing in New Jersey across the country, but also highlighting other areas that are doing really cool, innovative work and making sure that they have a voice as well. It kind of was born out of this idea that there's a ton of conferences and, academia around the medical side of things. And then there's a ton of things happening in the social space that are not funded by, insurance or just the traditional models. And like, we know and on the ground, and I'm sure all of you do as well, that all of those groups work with one another when they're actually doing the patient care at the point of care. So how do we elevate those stories and at the same time give a space for patients to have a voice as well? So we have a consumer scholars program where we actually have funding to be able to bring patients who are advocates in their own communities to our conference or to present at virtual webinars and things like that, so they can explain for them what drove them to be an advocate and how do they continue that advocacy work, which is really cool. So that's just kind of an overview of what the Camden Coalition does. And so to talk specifically about the HIE, so this is my kind of slice of work within all of that. We have had an HIE since 2010. It's been really receiving most of our robust data since about 2012. And we've expanded to really, even though we're called the Camden Coalition HIE, we're really focusing on multiple counties in South Jersey. So we kind of have this dense, smaller area of the state in which we're doing a ton of work. So in the middle, there's some examples of data points. If you're familiar with HIEs, this is pretty standard. We're receiving admissions and discharge transfer feeds. We're receiving lab results and discharge summaries. And then along the bottom is sort of where we're having our bidirectional feeds. So our hospital partners, we're pushing and pulling data to them. Our Camden Coalition Care Management team is documenting in our HIE. So that has been a really rich source of data because, if one of our social workers is, documenting their kind of interactions with the patients and say, a food pantry or in terms of housing, we do run a housing first program. And so where our teams are documenting in that, the patient's primary care provider or the patient's ED physician, for example, is able to see that and see that relationship. And that, that's really critical. We're going to connect to other HIEs throughout the state of New Jersey. One really interesting data set that we have that we've done a ton of work with is the Camden County Jail. And so their clinical staff, we're receiving data from them every time a patient has a visit. Excuse me. And then also they have a really interesting program where they're referring patients to medication assisted treatment outside of the jail once that patient is, that individual is released. And so we actually use the HIE to build that referral platform. So that way there's a maintaining a relationship and a warm handoff that often doesn't happen in the criminal justice system. Most often patients or an individual is leaving the jail and they're just out. And with that extra support from the clinical staff in the jail and from the medical staff outside of the jail, it's been really, really interesting to see. On the left side of the screen, we're receiving lab data. We're receiving a lot of claims data from MCOs and Medicaid in New Jersey. And then we're also pushing data to a lot of groups. And this is sort of where I wanted to focus today. We do push data to a lot of community partners in multiple different spaces, and I'll talk about some examples in a moment, and also faith-based organizations. We have a faith and prevention program, which is modeled off a program that was started in Memphis, Tennessee, where faith-based leaders who had a really strong relationship to their members are receiving alerts in the HIE to know when one of their patients is admitted. And I'll talk about that in a second. But this is just kind of the general overview of sort of our ecosystem of an HIE. And then one thing I'll mention that I think is really important to kind of this group as we're thinking about governance is that the Camden Coalition is designated as what we call a regional health hub. So back probably in, I would say like 2013, 2014, the very popular, trend or terminology for things was NACO, so an accountable care organization, which I'm sure you're all familiar with. And a lot of times that happened in the Medicare space. In New Jersey, we piloted, what if we could have Medicaid ACOs? What if we could have places where they were receiving Medicaid claims? We had a duty to connect with community partners in order to work with patients. And so we were considered a Medicaid ACO for a few years, along with the other major cities in New Jersey, in Trenton and Newark. And what ended up happening from that was that because the Medicaid ACO, we were getting info from the state, but we didn't have a voice or like a concrete enough pathway to relay learnings up to the state or to MCOs to actually change what they were doing. We actually advocated to become a regional health hub. And so we're designated as of February 2020. And then we're part of sort of the legislation of New Jersey. So we're guaranteed funding every year, and we're also just considered kind of part of the Medicaid office, which means that we have a lot more visibility and we have a lot more ability to affect change, which is really important. We're mandated to operate a health information exchange. We're mandated to convene community stakeholders. So we do have a responsibility to get together community partners in multiple different sectors regularly to talk about data exchange and ways in which they could pilot what they're doing, what's being successful at a larger level and scaling that. And then we serve, like I said, state departments as a strategic planning partner. So thinking about across the state, how are we thinking about new clinical models or funding that goes towards housing and how we determine eligibility and things like that, how we can at the coalition better advocate for patients that may not be eligible for certain programs to make sure they're available, et cetera. And so all of these activities, are really focused on performing quality improvements and things like that. Implementing social determinants of health screenings. I didn't focus on this too much in my presentation, just for sake of time, but the Camden Coalition is also an Accountable Health Communities recipient. If you're familiar with that program, it's a CMS program in which we're screening for social determinants of health. And so we've kind of aligned that activities with the Regional Health Hub request. So that way we are offering this tool. And I'll show you some examples of that in a minute. But yeah, I think one important thing to think about is the fact that we were doing a lot of this work and then in parallel working really hard to get the state to notice it and then making sure that we became part of that program so we could continue that work. And I think that's one reason why we've been successful. So just to talk about some ways in which community-based organizations are utilizing the HIE. One great partner has been Volunteers of America. They are managing a lot of the housing shelters in Camden County and surrounding areas. Back at the beginning of the COVID-19 pandemic, the Volunteers of America, they had been using the HIE already to try to make sure that anybody coming into their facilities, they could identify if they needed any extra medical attention or care coordination services. But at the beginning of the pandemic, they noticed that there were quite a few patients who were getting tested for COVID, having to wait 7 to 12 days for a lab result to come back, and had nowhere to safely quarantine. So they got funding along with some of our hospital partners to manage a quarantine hotel, as it was called. And they needed a way for ED physicians to refer patients to that hotel. And so I'll show you a screenshot in a moment, but we use the HIE as that referral platform. So a patient would go to the ED, get referred to the hotel. Volunteers of America would offer social services. The Camden Coalition offered some more medical services while the patients were there. And it was a really successful program to help make sure that folks weren't coming back to the shelter and potentially spreading COVID amongst other folks who were there. Oaks Integrated Care was a behavioral health organization. We're actually in a pilot right now to be able to bring their data into the HIE, which is really exciting. But in the meantime, we've been pushing emergency department notifications to them. They're piloting new transition of care workflows in which the ED is actually referring patients to their behavioral health substance use services. And so they use the HIE in that way to sort of couple and organize everything together. Northgate 2 has been a long-term partner of the Camden Coalition. It's actually an apartment building in Camden, New Jersey that has always had a small team of social workers in the building because it tends to have seniors who are low income living there. And they use the HIE so they can know if someone from there who lives in their building has been admitted to the hospital. So that way when the patient is discharged, they can make sure that they're knocking on their door saying, do you need anything? Can I pick up your medication? Can I arrange transportation to your primary care, et cetera? And they're just really offering them that extra support. Northgate 2 actually started on the HIE because back a long time ago when we were doing that initial population health analysis and identifying sort of, for lack of a better word, the high utilizers or the super high utilizers, that building specifically was identified in Camden to say that there's a lot of patients here who are going to the hospital often. And so they've been a long-term user of the HIE and it's really turned things around and they offer really, really wonderful services to their residents. And then finally, I'll mention we have like I talked about before, we have the Faith and Prevention group. And so those are faith-based leaders that use the HIE when their patients are admitted to the hospital, again, to offer social support. We've seen anything from, faith-based leaders visiting the patient in the hospital, and, helping arrange transportation home and to their providers, and medication delivery and things like that. And we've seen it be as simple as, your faith-based leader is stopping by their house to feed their cat while they're in the hospital for 2 weeks. And that little bit of extra social support, I think, has really gone a long way. So just some examples, and these are just some, I apologize if they're a little blurry, just like some screenshots of examples of things we've been able to do. This is a referral platform for that quarantine hotel. And what has been really cool is that it's actually been able to be used by multiple partners. So the first person in would be someone from the emergency department at one of the local hospitals, starting to fill out some information on who the patient is. The next person to look at it would be someone from the Camden County Health Department, who would confirm that this patient's eligible for the stay at the hotel. Then it would go to the Volunteers of America team for social service coordination and to fill things in, like which room is the patient in, how do we how do we know how long they're going to be here? Do they have any other planning? And then finally, who their Camden Coalition nurses. You can see mentioned down here, Janine is, one of my colleagues who's a nurse who, okay, great, I'm the one assigned to this patient to work with them. And then, so this is an example, this is all real patients, but de-identified, an example of sort of when we have these referral platforms and we're able to look at all of that information. And then the Volunteers of America team actually got this dashboard. So we can see these are examples of 4 patients that were in the hotel. We can see the date that they were tested, the date that they arrived at the hotel. Do they need an extension because we're waiting for those test results to get back? Where are they located, et cetera. And then on the very last column, you can see the lab results. So that's, and they were coming in from a LabCorp or BioReference or from the hospital directly. So that really important kind of information all coming together really made a difference, I think, in just making sure these patients felt taken care of. We had a lot of patients who, were staying in the hotel because they were asymptomatic and even just probably not even considered homeless by any means, or even housing unstable. We had examples of patients who were like, I live with an elderly grandmom. I don't want to get her sick. I don't know what to do. And they were able to come here and safely have a place to kind of just stay. We had patients who, were asymptomatic, but had, other conditions like diabetes or asthma or things like that, where they were saying that they just needed to make sure they were still getting the regular medication or getting regular dietary needs, et cetera. And we were able to help, kind of support all of that. And the IHIE really was that central place where folks felt comfortable going into to document, looking at information, et cetera. And I think because we had really set it up in a way that was patient-centric and making sure that what we needed to know about the patients so they didn't have to keep repeating their needs or things like that, that it was all kind of brought together. Another thing that we're doing as part of being a regional health hub and as part of our Accountable Health Communities work is we are exploring launching My Resource Pal in the IHIE. So My Resource Pal is our white label name for Aunt Bertha. So hopefully folks on the phone are familiar with Aunt Bertha, and there's other similar platforms like NowPal. I'm blanking on the name. Unite Us is one of them. And so it's a very similar idea of having a place for social services directory and referrals. We use Aunt Bertha in the Camden, kind of New Jersey, Philadelphia area. And so we have a white label called My Resource Pal. And what we're doing is, this is an example of a patient's record in the IHIE, and we're actually exploring being able to launch our screening tool right within the patient's record. We have a ton of examples of providers who are, I'm in a primary care visit with my patient and we're discussing their medical needs, and they're talking about the fact that they're struggling to pay their utility bills, or they're worried about putting food on the table for their family. And so this section allows them to actually click into this and start filling out some information about those 5 domains, and the 5 domains for the Accountable Health Communities program that we also focus on is, again, housing, food, utilities, transportation, and interpersonal violence. And so again, being able to fill this out and also be able to find resources right from the HIE that they can then print out, papers and share them with patients. The other cool thing we're doing in Aunt Bertha is actually making direct referrals, and then we're closing the loop on that. So we have a few community-based organizations that are actually primarily receiving referrals for their services through Aunt Bertha, and going in and actually checking off to say, this patient did show up, they are enrolled in our services, here's the program that they're in, and then that message gets sent back to the original referrer. Because as I'm sure, it's a common thing across the country, and I'm sure you're all aware of things like, I told my patient to go to this place for this service, but I don't know if they actually went, and I don't know how to get in touch with them or how to find out if they did and where to document that, et cetera. And so we're trying to build that all into the medical side of folks using the HIE, and pushing data between the two systems, so we can look at things like how many folks at your practice, had a high rate of inpatient utilizations and also had a social service need that they identified through the screening platform. So we can better think about what are the appropriate workflows to trigger, actually knowing what the full situation of the patient is, or having at least a fuller picture than just what their medical utilization has been. So going back to kind of my original title, because I feel like I talked a lot about the actual content of the work, but how do we determine governance structure here? I mean, I think one thing I can say is that we don't have it totally figured out, and I don't think anybody does. And I think, one of the reasons why I joined the presentation today was working with some members of a larger HIE collaborative called the Strategic HIE Collaborative, or SHIC. And Waldo from the Indiana HIE reached out to me, and he and I together, along with some of our committee members, have really been grappling with this. And so I wanted to share some of the things that we think is important and been useful to us in our area, to see if you could adopt something similar in yours. One is that any organization that participates with our HIE does sign two types of agreements, a business associates agreement and an HIE participation agreement. And that just explains that organization's responsibility to uphold HIPAA. I think sometimes in the past, our health systems or our more traditional healthcare partners have been a little nervous about, like, oh, I don't know if this housing shelter should get access to the HIE, what about HIPAA or things like that. And just having like a concern that because they're not considered a covered entity, that they may not, use the data appropriately or something like that. And what we do is sort of say, they're still signing a business associates agreement with us. They're still signing our participation agreement, which overviews all the ways in which they need to uphold the standards of the HIE. And we work really closely with them to make sure that they understand that, but also that we're building the HIE in a way that benefits them. The faith-based leaders, for example, when they use the HIE, they say, they have said to us, and we agree, that they don't need to go in and actually review the patient's medical history. They don't need to read a discharge summary. They just need to know, I'm Christine, I go to this faith-based organization, I'm in the hospital, and I'm going to be there for 6 days. They need to know that sort of thing just so they can work with us. And so it doesn't need to be the full medical record and things like that. And we really work with them to make sure we understand what's the minimum amount of data you need to do something productive for the patient. We also operate an HIE oversight committee, which has largely been health system partners providing governance, but now we're kind of actually expanding that to include more organizations. And so we're trying to get the committee to be a little bit more strategic with us. And how do we bring in social service partners or community-based partners that your health systems are already working really closely with to the HIE. And they've been a great great partner in helping us, govern the data and make decisions about use cases and write them in a way that fits everyone's needs and stays within compliance, but also inviting more folks to the table. We've done a landscape analysis in multiple ways to understand success in other communities. So one thing I've done is, when we started to get into the behavioral health space, I reached out to other HIEs to say, how are you managing consent? How did you convince stakeholders that you could be responsible for this type of sensitive data? How did you, who did you engage with first? And did you pilot something, or was it a large scale effort, et cetera? And again, with my last bullet, piloting with smaller groups tend to be more successful for us, where we can say, for example, with the BOA, that pilot was so successful of their staff using the HIE in a way that really was beneficial to the patients, that we are now actually, in the next few weeks, we're having an invitation to housing providers all across Camden to join and learn about that pilot and say, how can the HIE be beneficial to you, to invite more to join us. And so we kind of take that approach of having a really strong, small pilot with a lot of lessons documented, tweaking workflows, identifying gaps, identifying systematic barriers that, like, no matter what we do with the pilot, nothing would change that barrier, and then saying, how do we scale from there? And I think that's been really successful and made really partners a lot more comfortable with the idea of expanding use and access to the HIE. One of the last things that I just wanted to mention from a data perspective, so I know a lot of folks on here are probably familiar with the DASH programs and grants in terms of linking different data sets and how can we understand sort of the patient's fuller picture as they go through different systems. This is one example of a program we did a few years ago where we were looking at arrest history and police encounter history and claims from an emergency department. And this is actually a real patient who had all of these interactions with both systems, and then their housing as well. And so it's a little bit hard to read, which is sort of the point of the image, is that we had, multiple examples, of patients. This was not in no way a single individual or an outlier, who was interacting in all of these different systems. And as you can see, for a long time was just never getting the care or the services they need. This patient was, going from a hospital to getting arrested to addiction treatment services, back to a hospital, back to addiction treatment services, suddenly homeless, et cetera, et cetera. And when we showed this to some of our leadership in the Camden area to say, whatever we're doing is not working, and just helping them just kind of understand that all these multiple systems need to start talking to one another. This kind of work we did in this research did help us get more vouchers for patients to have more supportive housing. It did also help us get a better connection with our Camden County Jails clinical data set. So, we did not fix the problem by any means, but we're working towards that. I think it's a really good example of how that can happen. Just being mindful of time, I apologize. I know I was supposed to give some time for questions. Just wanted to make one last pitch, is that we do have a conference in October for Putting Care at the Center. It's run by our National Center for Complex Health and Social Needs. I mentioned this at the beginning that it really is a space for providers who are doing innovative work in the medical and social space to come together, share learnings, interact with one another. And I think that it's a really great opportunity to network and do things kind of like what we're talking about today, just sharing learnings across communities and sourcing solutions to problems and talking about how this can all, how we can all support one another. So definitely recommend checking it out. There's a lot of opportunities in the meantime for webinars and things like that. So just wanted to highlight that here because that could be of interest to this group. And again, just want to say thank you for this presentation. Apologize for going over a little bit, but would love to answer questions and things like that if anyone has them.
Christine, this is outstanding. And I don't know if you have a chance to kind of open up the chat window, because I think normally I try to kind of roll up some of these things, but you clearly have driven a lot of wonderful kind of discussion kind of even within the chat. If you scroll up about 20 posts, gives you an idea how many questions people are having kind of based on all the wonderful information you shared. I think the first question here is from Bill Tierney, just around kind of the funding model for your HIE and the business model that sustains it. And see if you could touch on that. And then honestly, feel free just to kind of take a look at the chat and pick them off as you see fit.
Great. Yeah, so our funding model on the HIE side, we are a mix of some state funding. So as being a regional health hub, we do get funding allocated to our HIE through that, and also through our health system partners and MCOs that participate in a variety of ways. And then otherwise, we look for some grant funding here and there, specific pilot programs, because like I mentioned, we might be doing a pilot with the behavioral health group that's utilizing the HIE. So it's sort of jointly funding the care management design or care coordination design, and then the HIE itself. And so having that regional health hub designation has really helped us sort of have a pretty steady baseline for that. Yeah, wow, there's a lot of questions. This is great. I see one here about like common issues stakeholders regarding data and concerns, with CBOs accessing HIE information. And I touched on that a little bit, but I think, having, an oversight committee, like I mentioned, that's really involved in developing our use cases. And we, develop use cases often in mind with what are some examples of ways in which we can implement this right away, or that we're already implementing this and want it to be, solidified. That's really helped us. We're also, heavily involved with just understanding from a CBO perspective, what's your consent model to either gather information for patients or to share information for folks who are utilizing your services with other providers, and sort of making sure we're having those conversations as well. We've been really able to work through that. I think being prepared for that specific question. I think that that's an easy one to kind of derail any type of work if you're not prepared to answer how do we protect patients' privacy. So that's always been really important. Let's see. Great. So yeah, so there, I see a couple questions around referrals for non-medical services, and one specifically around services for folks with substance use disorder. Yeah, so we have built out in our HIE pilot where participants are able to kind of use the HIE and identify patients that fit our specific model. So I think for the pilot, we were looking at patients who had 3 or more admissions in the past 6 months for substance use or mental health related diagnoses, are currently in the ED for that primary diagnosis of some sort of substance use or mental health, and then can refer patients directly to the Camden Coalition or our behavioral health partner, depending on an assessment. And I think some of this is public, so I can probably find some information to share a little bit more concretely, or welcome folks to reach out to me to talk to my colleagues. But there was an idea that, some of those patients really do need more medical needs, and some of those patients may not be having as severe of a diagnosis, but the fact that they're housing unstable, or they don't have, consistent access to food and things like that, is exacerbating their substance use disorder. And so we were taking referrals as well. And so we're using the HIE as a place to say, we confirm that we're working with this patient, so closing that loop, and then being able to have regular case conferencing with our hospitals to be able to talk about those patients, that they referred to us. So that way we're, really closely aligning with them and the times that the patients do come back to the hospital. The toughest thing for sure is the fact that once patients enter into some sort of substance use treatment, you have to think about 42 CFR and the consent models for that. And so we're trying to help our partners structure consent forms that allow patients to opt into sharing data with all of my current and future providers, and acknowledging that the HIE has a role in that, so that going forward, if a patient at any point chooses to opt out or rescind services, we at least have kind of a clear way to say, like, we were able to serve them for this period of time, and then they chose to opt out. And we're trying to do some fancy things in the HIE too, with flagging sensitive data that's only available to specific providers. So to be honest, it's pretty messy right now because it's new, but we're working, I think, through, trying to figure out how we can scale it. So that'll probably be the next piece. Yeah, and just in my last minute, Darshan, is there any other specific questions that you see that you think would be useful for me to answer now? I'm more than happy to connect with folks at any point. My information's on the screen if anyone ever wants to reach out.
Yeah, that's what I was going to maybe suggest is if you wouldn't mind, we could send forth these questions to you even after. Realize
Sure.
I think there's a lot of really good questions here, and I'd hate to not address them. And then obviously, folks have your contact information, so we can obviously kind of follow up with additional questions as the day kind of progresses as well. So
great.
No, but this has been extremely eye-opening. This was we wanted to get inspiration from national models, and this certainly hits right squarely kind of for what we're seeking. So thank you so much for that. This has been absolutely wonderful.
You're welcome, and thanks for having me. It's really always a great opportunity to be able to share things, and please shoot me an email if anyone else has other questions.
We certainly will. Thank you so much. All righty. Well, what a great to start the morning. That was fantastic. So our next up for the day is a panel discussion that's going to be led by Brian Dixon to talk through some of the things that Christine has kind of teed up for us this morning around governance and data sharing challenges, and obviously things like informed consent and all these other kinds of potential features to kind of help tackle these kinds of problems. But really, I think I can probably just hand over to you, Brian, to kind of lead the panel.
All right. Well, thanks, Darshan. Good morning, everyone. So I'm Brian Dixon from the Regan Street Institute and the Richard M. Fairbanks School of Public Health. So I appreciate the amazing talk, Christine. So I was taking a ton of notes, so I was furiously typing away, and I'll definitely be reaching out to you. So I want to kick off. We have a great panel here with a number of folks, including Ammon Fillmore, Bob Davis, Lena Hackett, Sharon Kandris, Owen Boberg, Carl McKinley, and Chelsea Winters. So thank you to the panelists for your time. So I'm going to kick things off with a brief overview. Around governance, we've heard yesterday, it came up a couple of times in talks that governance is important. Christine did a fabulous job of talking about their governance. The analogy I use is that governance it's sort of like, imagine you came up with this amazing idea for some new invention, and you created your company to go out and sell that product, but you didn't put any leadership in place at your organization. You just had the kind of paperwork done, and the idea was out there, and then you just expected people to, buy it and you would become a millionaire. But you don't put any leadership to actually drive the organization forward. That's sort of like, having a data resource like an IHIE or a registry or something, and then, not putting any governance in place. So in order to really have use of your asset and have it be used to do good things in improving, health and well-being for populations, you have to have governance in place. So some critical components of governance, and these are things that I think our panelists can touch on. If I just share this screen with you real quick. And this is from a chapter in a book on health information exchange written by Keith Kelly and others. But you kind of have three components in place. One is you've got to have a governing body. So Christine, again, illustrated this nicely in her talk. You also, that governing body has to create and own policies and procedures. And from that, then you have things like data use agreements, participation agreements. So you have to have all these components in place. And while these are sometimes the boring parts of, sharing data and collaborations, they're really critical to this success because they build the foundation for you to do all of the amazing things that you want to do in terms of saving lives, improving health, improving outcomes. And so I think these are some of the topics that our panelists are going to talk about. So I don't want to take too much of the time here and really want to just kick things off with kind of a first question to our panelists. So specifically, Ammon, Bob, Lena, why do you feel governance is critical to the successful data sharing initiatives from your perspective in your organizations?
Thanks, Brian. I'll start it off. As a health information exchange, we essentially are an intermediary in many senses. We are not the owners of this set of data. We are data. So data governance, kind of along the slide that you showed, it's about building that deeper level of trust. If you don't have consistent and comprehensive data sharing framework, data governance framework, it's going to be really difficult to convince your data contributors that your data recipients should be able to use the data, and you end with data silos, which is counter to really the very purpose of social determinants of health. It's to enable that data sharing. So at a fundamental level, data governance provides trust and transparency that can assure groups and individuals that their data is being used for a permitted purpose.
Bob or Lena, you want to weigh in?
Sure, I'll jump in there. Good morning, everyone. Thanks for this opportunity. We look at this as exactly what Ammon had indicated, but to expand on that is assuming you have the governance body, assuming you have policy procedures, data sharing agreements, things like that, you want to have those to expedite the sharing of data. As you researchers know, a lot of the researchers know, it's very painful to sit there and you have approval to move forward with research, but you can't get the data for various reasons. And being at IU for 12 years and working with research, I know how painful that can be. So that's real important. And the other point that I would make there is to ensure that when we do provide data, it is complete and of quality. That's extremely important. So a lot of the things that you do in data governance, in my opinion, assist with that completeness and quality of the data.
Any thoughts, Lena? Okay, let's move on to the, oh, go ahead, sorry.
Oh, I would just add to that. I mean, our role also, is more as a data intermediary. We're collecting a lot of data and transforming it and making it useful to a variety of organizations for public reuse. But so critical to the governance is just assuring that we have consistently produced quality, reliable data. So we need to have those policies and procedures in place to ensure that the information we're taking in and transforming is appropriate for the intended use, making sure that they are high quality and making sure that they have reliability to them. And also associated with that is just making sure that as we're thinking about the kinds of data that we're taking in, a lot of us are dealing with confidential data about individuals. So those procedures also ensure privacy of human subjects and security, making sure that your data is secure in the way that you handle it and the way that it's exposed to others, to make sure that there isn't inappropriate use or access by unauthorized users.
Mm-hmm. So we've talked a little bit about the importance of it. Now I'd like to ask the panelists to kind of weigh in on some of the common challenges that you face in with respect to data governance from your perspectives.
I can hop in. Chelsea Winters with the YMCA of Greater Indianapolis. So I represent sort of the CBO view of receiving these referrals and setting up these systems. And I would probably argue that the Y as a national organization is large in the community-based organization space. And for us, the challenges around data governance and really setting up these referral channels, we don't have in-house counsel. So every time we go to set up a BAA or set up our systems to be able to receive these referrals, it's a significant cost for us to engage external counsel to be able to review those systems, those documents, those agreements. We kind of joke now, but I think it literally took us 5 years to sign our first business associate agreement because we had to go through all of those, Ammon can talk to this, obviously, all that security review, all of those systems, the data that the Y stores and keeps every day for sort of the core of our business is not PHI. We're not submitting it for reimbursement. We're not exchanging it. Our membership software is not really set up to be a HIPAA compliant system. And so it took us a good 5 years of work to adopt new systems, identify, where this PHI was going to sit, figure out how we were going to use it in a way that was, not super staff intensive on us. I mean, for many years, we accepted referrals and literally put them in a HIPAA secure spreadsheet, which then requires a lot of management on our end to be able to send feedback loops to our providers in a way that's efficient and gives them the data they need. And so the cost and the staff time and the infrastructure needed for a community-based organization to even get to the point that they're ready to sign a BAA, which we all know is only the first step in setting up these referral systems, is huge and time intensive. And traditionally, the reimbursement model doesn't sit on the CBO side. And so we're doing all of that work through grants and partners and board members who are offering to help us without any real promise of reimbursement or sustainability on the funding side. And so, it's been a steep learning curve. It's been a long road. We've been in this work with the diabetes prevention program. We did the original research with IU School of Medicine and DTRC to translate that before Medicare reimbursement came along. So we've been in this work here in Indianapolis for 10, 15 years, and we are just now getting to the point that we feel comfortable signing a BAA, maybe in 4 months rather than 4 years. And so that infrastructure and investment on the community-based organization side to even receive those referrals, let alone use them in a way that's actually efficient and serving the patient is really pretty steep.
Thanks for that great perspective. We could probably spend a whole hour on that, but I want to give others a chance to weigh in.
Yeah, from Regenstrief's point of view on the research side, and for data governance, it's working with sophisticated entities and unsophisticated entities. And so an unsophisticated entity that has social determinants data likely does not have any processes at all. They have a gatekeeper. They have one person who can say, yes, we will do this, and no, we won't do this. And so even finding out who that person is can be challenging. And then once you find that person and if they greenlight it, then often it's pretty easy to get data to start to flow or exchange or share. In a sophisticated company, like IHIE or Regenstrief or others, where we have committees, we have staff that are committed to working on existing processes in place, and that it's efficient and streamlined. And when you're dealing with those sorts of entities, it's not a matter of capability or capacity or those sorts of things. It's a matter of trust. So in other words, if I have data and I want to provide it to someone for some purpose, do I trust the recipient to use it for only that purpose? If I don't trust them personally, like this is from individual to individual, if I don't trust them, then it doesn't matter about the legality or the permissible use. It really comes down to, do I feel safe? And frankly, most of the time, this is about people and the relationships they build, and also about a person's competence in the subject matter. So when I'm working with someone and it's permissible, it's legal, there's no reason not to be able to share this data, and we have a conversation and they start saying things that I know are patently incorrect about data security or privacy law or those sorts of things, it's a huge red light for me to say, like, I don't know if this is a good idea, because I just don't know if I can trust them with this.
Yeah, others, please jump in. Owen?
Yeah, so yeah, I'm Owen from MPH, and I will just kind of build on what was just said, in that a lot of kind of what we have to do at MPH, right, is because we're just kind of bringing in everyone's data from other state agencies and we're stewards for these data. We're constantly dealing with a number of different regulations that we have to figure out. And it is kind of understanding that trust, right? So you have to consider HIPAA and FERPA and CGIS, and you'll have people come in and they'll ask for data be combined in a certain way. And then you just have to make sure that you're still going back to your partners and explaining how the data might be combined, and then understanding how the intended use might fit within the frameworks of the regulations that each one of these agencies is expecting. And that's always something that we continue to deal with at MPH to ensure that we're continuously delivering a trustworthy data product, that one, the researcher knows is what they're expecting, and that we're not giving out anything that our partner agencies weren't expecting to get out there and be used in some way that is beyond what they agreed to. So those have continued to be something that we kind of are always going through and continue to work with. And because we're not kind of creating any of our data in-house, we're always kind of just having to be flexible and be transparent and continue to work really closely with our partners to make sure that the ball is never dropped and that we really are pushing out data as a product.
I can answer from our perspective, and just maybe a little bit of background, because I was looking through the list of who's on. I'm not sure everyone's familiar with the Polis Center. A lot of our work involves democratization and reuse of government nonprofit data to address various community challenges. So in that work, we're curating and assembling a lot of data from about 70 different data sources and converting those into meaning community level metrics. A lot of that, and we're always like geo-enabling those data so that we can understand communities in place and the challenges and opportunities they face. We're often dealing with confidential data, administrative records that come to us in messy format. So, we're trying to negotiate agreements so that we can gain access to data on behalf of a variety of stakeholders and partners, and then redistribute those data in more meaningful ways. We also create actionable information out of those, and we work with a lot of organizations, particularly nonprofits, on how to use those data effectively for action and change. Informing decisions, policy, programming, strategy. So in that process, there are like 2 or 3 maybe challenges that I would want to highlight. Just in, we've the SADC community information system has been around for 25 years. And we've had long-standing relationships with data providers like within the city and county government, within nonprofit organizations. But more recently, and we've had these data sharing agreements, long-standing data sharing agreements, and some of those are now coming back and realizing the potential risk of sharing their data. So particularly within government, we like I said, we had a long-standing relationship with the city organization and or city agency. Something happened somewhere within the city government. There was a data breach. The attorney general got involved, and suddenly the city's lawyer just was all about shutting down every data sharing agreement that existed without really knowledge of what it means, what the data sharing protocols are in place. So we spent a lot of time just helping them understand our data governance structure, all the policies and procedures we have in place, this technology and methods we have in place to assure that those data are protected and confidential in a way that assures them. But the challenge really was that the lawyers didn't really know and understand what it was. So they wanted to deal, our lawyer to their lawyer. They didn't really want to get in and understand the intricacies of the data and the privacy and security, all those things that we've been developing over these past, several years. So we've experienced similar things as we're working with nonprofits, really kind of the risk and the concern about, okay, what if I expose this data? What if something happens and it gets released? What are going to be the implications? So there's just a lot of, aside from the technology piece, a lot of legal issues that we're kind of revisiting with organizations we worked with for a long time. but also, just newer organizations that are kind of embracing this data culture, just not knowing what it means, to share your data or to use your data for different purposes besides administering your program and understanding, the clients that you serve. So we've been working quite a bit on, trying to build that confidence, help understand, ways in which you can protect your data, ways that you can share that in ways that will reduce the risks with those organizations. So I think those are a couple of things, and there's lots of challenges, but I think the legal and ethical challenges, often are more at the forefront now for us.
Yeah, good points. And I wanted to pick up on one of the comments that Greg put into the chat, because it seems like, it's not really technical issues that bogs things down. It's some of the legal, ethical, and then also the incentive issues that Chelsea mentioned. And so I'm wondering, what are the panelists' thoughts on to answer Greg's question around how to structure governance systems to kind of address the, if you will, disparities between organizations like in the community, like Chelsea represents, versus the healthcare entities, the payers, the kind of more established healthcare entities that stand to sort of benefit financially from some of these relationships versus the community organizations, if you will, that have important data and who also have important services that they offer to patients in coming up with either agreements or helping them get involved in some of these activities. So I'll stop there and see what thoughts are from the panelists.
Yeah, Brian, I wanted to make a point on Greg's second question, and it goes to the graphic that you presented earlier. Having a committee, committees are really good in data governance to decide what are we going to do, why are we going to do what we want to do, and to put constraints on things like we're going to provide data to anyone who asks for it, or any non-commercial entity may receive data, whatever the constraints the committee wants. That's the stakeholders of the data. However, committees are very poor at operationalizing the processes involved in data governance. In other words, if you have a committee who's going to be the approver of the disclosure or access of data, you have a very inefficient system because it cannot react in real time. Instead, a committee creates this sort of framework, these uses and these restrictions and these permissible uses, and then that is then given to, I would say one person is best, that you have an expert that's used to dealing with these things, and it's certainly never a lawyer, that then operationalizes through process and policy the will of the committee. And then those processes and policies can then streamline the decision making. You can make categories, you can make checklists, and then you can filter those things down to your employee level for them to make decisions based on criteria that your lead person has verbalized based on the contracts and the agreements and the law and the committee's will for sharing the data for that purpose. And you will find that doing it that way is much more repeatable. It reacts in real time. You'll get much more consistent decisions makings, and that will eliminate the conflicts of interest there, where you're sharing. You don't want to necessarily share data with one group and not for another group if the purposes are the same. That's sort of discriminating against that group. If it's certainly, you would never make those decisions based on revenue generation. That would be unethical, in my opinion. So that's my answer to Greg's question: is that the committee is good for creating the permissible uses and the restrictions, but then that must be operationalized by a team.
So, Brian, I would echo. It really illustrates well where, for example, I poke fun of my other lawyers friends who are real estate lawyers, and hopefully there's none on this call, but they have precedents and they can look at case law that literally goes back for hundreds of years. In the world of data privacy, it's so incredibly dynamic in data can be used, the law doesn't keep up with it. And frankly, the laws that we have in place are arguably antiquated. And so data governance has to comply with law, but in many respects, those policies and processes that Carl is talking about, it picks up where we have a vacuum where the law doesn't provide a lot of clear guidance. And so that vacuum has to be filled with the appropriate expertise, the appropriate committees, the appropriate individuals that understand the context in how to appropriately execute this, where there isn't a long-standing precedent that you can historically look to, or that a judge has said, yes, this is the way that you have to do it. When you don't have that, you've got to build clear processes. Otherwise, you and I hope I'm not stealing Carl's words too much, but Carl said that it'd be replicatable, that it's replicable, right? Carl, correct me on that one if you didn't, but that's the key to building that trust, is that you can make it replicable when you don't have those long-standing precedents.
Mm-hmm.
I'll just echo, I mean, we've sat internally at meetings and said, we don't want to be the case law for this. Let's send this out. So, I mean, yes, even on the CBO side, we recognize, I think especially, obviously in our healthcare referrals, partners generally understand what we can and can't do and the types of systems that need to be set up. But for a nonprofit that then also sits and relies on a ton of philanthropic funding,
can't make myself suffer.
that's often where we've had those conversations of,
Might be a bad
we can't do this, right? We have to think about what the funder's asking and where we sit at that intersection of referrals and what makes sense for us. Because there have been times and situations where we say we can't send that data because of what we do in this space or in this silo. So.
And I was going to add, at MPH and how we work on this and build these committees of who's kind of helping make these decisions. I'm on the technical side of the house as a data scientist. So what I try to do is to help our legal team and our engagement side understand kind of black and white what the data might be showing. And then, they will then have to interpret their law or what it might be or their agreements and how we can distill that down, as Carl said, into a simple checklist that can then be productionized, and that you can just take it and apply it to the same way. And then you're continuing to do things in a meaningful, consistent manner that will continue to drive value of the data that you might be hosting. So that's something that I think one of the cornerstones of data governance is that it should span all your teams within an agency and across agencies. So you're getting all these different expertises together. So it is kind of foolproof if you can get it that far.
Go ahead, Bob.
I would just add a few more comments to this. I'm learning, so from all this is great comments, guys. So I'm actually learning because we're going to have to establish such a data governance beyond what's been here at Health. So I think another thing is that the data governance is a living, breathing organism, if you will, and we have to be cautious of the makeup of these folks, these committees, these groups, because we do need to make them be efficient and effective. And so that's real key in the process as well. So yeah, you'd love to bring in everybody that can be part of that. But then again, you got to think of, what that means as far as pulling people together to make decisions and things of that nature as well. So you got to balance that to some degree. So that's important as well as you're thinking about pulling these committees and groups together.
Yeah, and I'd just add to it, just reading some of the comments and questions posted about the composition of the committee and how you ensure that it's not disrupted when someone leaves or something changes. I mean, I think and how we think about the committee structure is those that have a vested interest in the outcome of whatever it is you're doing. So those that have, all those actors, whether it's the data sharers, the data users, the data funders, all of those folks should have a voice at the table. And one of the audiences that we're trying to do a better job of incorporating, and that is kind of that democratic participation, where it's if you're putting out data about populations, involving those populations in the structure is really important. So that's an area that we're working to improve, because we've always focused on kind of the organizational level, the government level, and that kind of structure. So I think we'll be looking to expand that. It's also important. A lot of times we think about committee composition by people because of their expertise, but to ensure that sustainability, one of the questions that was posted in there, so there's some that we need to also think about based on their position. So even, so making sure that the position in an organization is a representative on your committee structure, so that as that changes, that's just already built into your process. So that, transitions in leadership and transitions elsewhere, it's kind of building that in. So with that, you have to balance relationships, because we often, tie into those that we have good relationships with. It just reinforces the need to establish really strong relationships as you're, developing that structure.
One of the other questions is that I'd like to, unless there are any other comments on that, is to pivot towards thinking about what impacts have COVID-19 had this last year on sort of data governance, like processes. How did the processes change at all? Because most of you are involved in long-standing processes and governance structures. So what impact did the pandemic have on forming new relationships or changing the process at all? And do you think that it will have kind of a long-term impact, or is it sort of limited time period to the pandemic?
So, Brian, I think at least coming from a legal perspective at IHIE, what COVID quickly highlighted for us was a lot of the legal barriers and gaps, and not said in a critical way, but our federal laws and some state laws weren't designed around the idea of we need to facilitate data sharing amongst coordinated entities that may or may not be part of the traditional healthcare ecosystem. And so it certainly put us in a position, in working with some fantastic partners at the Department of Health and otherwise, to find solutions to that. But it quickly put a spotlight on saying, hey, how we've traditionally done things isn't going to work when we hopefully have these kind of one-time sentinel events, and it forces an immediate adoption of hopefully appropriate measures, but then begs the question, what does a long-term solution look like for these types of public health events when they do occur? So I think COVID definitely shined a light on some of those fissures or vacuums of data sharing, where it was either not occurring or legally it was prohibited, or traditionally it just wasn't happening.
Yeah. I think from Regan Street's perspective, I think one of the changes was that there are events that are immediate and pressing, and that often, let's just be truthful here, like data sharing agreements can often be low priority. Okay, no one's getting sued, no one's business is going to go under. So everyone has a certain amount of bandwidth to work on projects. And so sometimes data sharing agreements can take a long time to get done, just because there's often low priority. I think that the immediacy of the pandemic changed a lot of that to it forced a lot of people to say, what can we do right now? Like we have to get an agreement between the state and Regan Street done in the next week. So let's do that. And sometimes you have to take a little bit of a leap of faith and say, like, we're all working on this with the same goal. There's no alternative plans. So let's start working together in a way that we assume that we're doing this for each other. And I think that was a real blessing, because I do think that a lot of, between IHIE and Regan Street and the state and hospitals and other nonprofits working towards this, I think that we did build a lot of trust. I think we did share a lot of data, and we still are sharing a lot of data, and nothing bad, knock on wood, has happened. And I don't believe anything will happen, hopefully not on my watch at least. And so I think that did build a lot of trust amongst all of the partners here in responding to the pandemic. And I think that that will translate into non-pandemic issues, other public health issues, other needs of patients, of the citizens of Indiana. And I can't wait to see what happens next. I think it's gonna be pretty amazing.
So one of the things I echo that it did seem to open up the doors to faster data sharing, more efficient data sharing. But I think the most critical thing was the collaboration around the use of the data. I mean, I know like the group that Peter and Regan Street pulled together was amazing. Just everyone was about, okay, what problems are we having? How do we solve them? And there was in other circles as well. It was really just a new way of, okay, this isn't my data. It's like, how we're just trying to solve a problem. Who's got what? How do we bring this to the table? And we can quickly work through, data sharing, challenges to get to that. And we had, more data access, I think, in this past year than we've had, across a number of years. So that was wonderful, and it was just great to see that community coming together around that issue. And I think for us, we tend to process data on a like maybe every 6 months to a year because it's used for planning and kind of long-term trends and trajectories. But we realized, okay, there are cases where we need to have near real-time data, and how can we get that? And it's just really making us kind of rethink our data structure and system and data governance so that we can get more quickly turn around information and be more responsive to these more pressing issues that are likely to come up more often. So it's kind of helping us think differently about the way we do our work as well.
I'll just add to that with coming into this role here at the health department in the latter part of September. I assumed a lot of things that had already occurred and still learning with respect to the COVID situation. And what I've understood is that collaborations within even the agencies within the state, for example, between us and FSSA, really grew during this past year and has evolved, and we're taking strides to continue that. And so we're working together to move forward with those types of things. But in addition to that, even our external partners, IHIE and Regan Street and others, a lot of good things. Unfortunate thing, we had a pandemic, but to some degree, it's also opened our eyes for a lot of things that could be possible that maybe we thought couldn't be possible. So that's all been good from that perspective. And hopefully the key thing there is that we act on this. We act on being able to move forward and advance and adjust some of the statutes and the laws that are in place. We have a lot of, I think, from what I can tell, we have things that are in place that's outdated, needs to be reassessed and moved forward with to help with some of this sharing of data going forward. I believe the executive order enabled some of that sharing much easier than maybe without it. But as that expires eventually or whatever, we have to move on, and hopefully we can pick up and put things and reassess and adjust what we need to do based on the learnings this past year.
Anything you want to add, Chelsea or Owen, to that?
Yeah, everything that has been said, I definitely want to see this motivation or momentum continue. And we got the executive order back in March of last year to start getting all this data together and using the MPH ERE. It was kind of like nothing I had ever seen before. I'd only been at the state for, I guess, a little over 2 years at that point, but it was just incredible to see it all flowing in, all this collaboration happening in such a secure environment, and just the results that started coming out of that so quickly. And it helps get these processes put in place to get the data sharing agreements moving more quickly, but also started to understand, to kind of highlight our gap analysis, right? Where we need to fill in data holes and how we can use these bridges that have been built through this pandemic to start to work on those and just make this a much better and robust system. So I hope that, as everyone said, like we can continue and use what we've gotten from this bad situation to do more great things.
I mean, we sort of sit at that like not the basic need level of social determinants of health, right? We sit at that next level of sort of preventing disease. And so in that regard, immediate sort of referral systems and data governance sort of slowed down, but we were able to put a lot more of the sort of long-term work in place around developing systems. Like I would say in the past, it's been us, as the Y sort of pushing the envelope on creating the systems. Almost, we kind of joke the pharmaceutical sales rep model, right? If we're not there all the time pushing the referral systems, we don't get referrals into programs. And I will say, I think during the pandemic, that sort of commitment or understanding that a lot of healthcare has to happen outside of the clinical setting if we're going to change the trajectory of public health and population health in Indiana, definitely has started to shift, right? And those agreements, those collaborative meetings are a lot easier. And we're hoping then that sort of has the foundation laid for, once we get out of this sort of emergent Band-Aid need, really shifting and looking at what that collaborative nature of clinic to community linkages, really looks like long-term as a way to prevent disease.
Just echoing what some individuals have said in the chat dialogue, which has been great, but if we're able to share data in an emergency, imagine how well we can share data when it's not an emergency. And I think that's the collective charge for us as participants and stakeholders amongst the social determinant of health ecosphere, is to say, if we can do it in an emergency and have to put in place agreements over, literally sometimes within 24 hours overnight to effectuate some really sensitive information and collaboration, when it's not an emergency and it's appropriately prioritized, this is sky's the limit. This is an incredible opportunity to continue what we've already proven we can done under incredibly stressful situations.
Yeah, I agree. Any thoughts on how we, continue to, make this a priority and put some things in place? Because clearly when you're stuck at home in a lockdown order and you're focused on, getting these agreements in place, it can be perhaps that facilitated some focus on, on COVID being a high priority. But once we go back to, trying to address infant mortality and diabetes and sickle cell disease and many other things, how do we kind of appropriately both prioritize what we're going to focus on, and then also, organizationally, make sure that it doesn't fall, as Carl pointed out, down back to the back burner, right? It goes away as a priority, and like, oh, I can get that, agreement done next week.
I think at least speaking for sort of the CBO upstream work a little bit, what we've started to explore over the last 2 or 3 years is not a scenario where, a healthcare partner exclusively runs something like DPP and gets reimbursement, or the Y exclusively does it. We've started to set up systems that allow each of us to sort of stay in our lanes and do what we do best. So the Y is sort of the low-cost community-based provider of group-based work. We pay a lesser amount than a clinical worker when it comes to sort of facilitating these classes and doing them in a group-based setting. This is what the Y does. And partnering alongside a healthcare provider that can be the sort of billing entity, right? And we can note in their EMRs the claims, they can send the claims. It allows the Y not to build out that sort of claims-based billing. And so that integration model that really allows us both to stay in our lane, do what we do best, but both share reimbursement or revenue for it, I think allows us both to appropriately prioritize it, right? When it's just the Y asking for referrals because we have a grant funded program we need to fill, it drops to the bottom of the list when it comes to figuring out the data and how to connect the EMR. When it's just the healthcare provider getting reimbursement and saying, oh yeah, we'll work with the community-based provider when we can, or when we have a gap we can't fill for a particular patient, then it becomes difficult to set up the system that works. But when we both sort of stay in our lane, we're able to share revenue in a way that makes sense and allows us both to really become more efficient, then I think we're both able, again, to sort of appropriately prioritize this work and setting up these systems.
Yeah, I'd like to make a quick note about prioritization. And I think we all sort of understand this. It's that, when we have our workloads and our boss comes to us and says, I need you to do this now, it's amazing how quickly we'll drop everything and do that one thing. Well, one of the reasons that we were able to do some of these things so quickly is because the governor said we need to do these things. And prioritization often is a top-down thing. So, when we're negotiating these data sharing agreements to get this sort of non-traditional data going back and forth, to say, I heard Dr. Box in a meeting say we need to do this. That's highly motivating to all the parties involved. And so I think as some of the questions we're talking about prioritization, about, maintaining this momentum, it's really going to be important that our leadership, whether it's, Peter at Regenstrief or the governor at the state, to say, like, I want this momentum to continue. I want you to do these things. Keep, think outside of COVID. What else can we do to help patients in Indiana? And I'm asking you to do that. And then they're saying to us, who are the experts, make it happen. And so that's what I know Peter says to me. I want to do this. Can you make it happen? And then I'll say, not quite like that, but I think we can do it like this. Does this get you where you want to be? And he'll say, yes, that's great. And then we'll do it. And I think that's exactly what we need right now. We need high level leadership to say, let's keep doing this. Let's do it, figure out a way. And then it's up to us in these meetings to say, how can we get this done? Can we get, is 90% of the way there good enough? Because don't we get stuck on 100%? Too much. Sometimes just most of the way there can still be really beneficial.
Yeah, that's a great point. I sometimes in jest say, ask the question to my team and colleagues, how do you eat an elephant? One bite at a time. We may not get 100%, but one bite at a time. 90% would be awesome. Build that pilot program that doesn't solve all of what we want to do, but it gets us some of the way. Success will build upon success. So prioritizing those pilot programs, those operations where you can prove that demonstrably this is achievable, and it can then be appropriately scaled when appropriately prioritized.
Good points. I mean, one of the things that resonated with me during Christine's presentation was the fact that, she was like, she often said, well, this is messy. This is still a work in progress. This is still, right. We don't have everything solved. So I think those are excellent points, right? We're not going to be able to, come up with the most perfect solution for SDOH data sharing overnight and put it in place within 1 week. But, we can make progress and make a plan. So good. Other thoughts on how we, kind of pivot from COVID to social determinants of health data sharing going forward in terms of governance?
I think, as was mentioned here, there's, the priority, who's establishing the priorities within that? What are we using social determinants of health to address? And if we can agree upon, the challenge or the, issue area we're trying to address, then everyone works together and collaborates around it. So maybe it's, one of those things is identifying, those sets of priorities to focus on, at least initially, again, with the low hanging fruit, kind of, making some small progress, quick wins, and then working towards kind of that longer term. Hey, we can solve all the problems in the world with this data, once we've demonstrated a few successes.
And I know from the Department of Health, we just issued our next 5-year strategic plan, 2021 through 2025, and it does incorporate objectives and strategies associated with data governance and sharing of data and things like that. So that is coming in from our leadership, Dr. Box and others. So that's on her radar. And so we're here to help make that happen.
I'm just reading through the comments in the chat that I think, amplify what you all are saying. So, and that, one idea in the chat is that, a collaborative to help push this forward could build on the success. I think, Sharon, I think you mentioned it, the Indiana Pandemic Information Collaborative, perhaps taking that organization or collaborative group, if you will, and maybe pivoting it to something like SDOH could be beneficial in helping to move things forward post-pandemic. Seems to be some sentiment in the chat. So good. I know we had some other I had some other questions specifically around, you know, challenges with governmental data versus private data. So do we want to kind of tackle those, or I think those would be useful, because as we go forward, it clearly, you know, there's data, you know, the CBOs probably have a different perspective on kind of unlocking data than, say, Bob, you at the health department. So what are some of those particular issues that I think we will need to face as a group to kind of move forward with SDOH data sharing?
For me, just again, learning about all this, most of my time's been spent strictly on COVID for the last 6 months or so. So I don't have a lot of insight here, but from what I can tell in some of the interactions I've had in working with NPH and others, is that some of the challenges that we will face or continue to face is the different agencies, the data that some of this data falls within for the state government, and trying to work with them to be able to break down barriers and whatever else you want to call it, to have more freely exchange of information and sharing of information as needed. I can definitely see that that's going to be a challenge. It probably has been and will continue to be. So we're looking to hopefully make some you know, dents in that as we move forward.
Yeah, from Registry's perspective, you know, from a health research side, you know, social determinants of health are often collected by the individual, not by an agency, not by a hospital. And so, you know, the world is changing about society's perspective on privacy is evolving as we speak. And there is this, we have to balance this need for data and the ease in which we can move data and collaborate on data versus respecting an individual's privacy wishes. And so one of the things that would be most helpful is having a more robust way of collecting consent from an individual and being able to monitor their consent so that we can, whenever they choose, they can decide not to participate with their data, and that it can be selective with their, it's not an all or nothing proposition when it comes to sharing their information. And there are ways to electronically collect consent. I would argue that they aren't, you know, oftentimes technology is driven by profits, and electronic consenting is not necessarily a profitable business. So it's not cutting edge technology, and it's not like Apple's making this amazing tool that we can use that's going to satisfy all of our needs, but emphasizing the individual collection of data and the consenting process, I think it would be really, really critical to facilitating the sharing of information. Remember, when you have an individual's consent, there's a lot you can do with it. Regardless, you worry less about state statute, you worry less about HIPAA, you worry less about all the laws when you have a really good, well-written consent that's monitored and that is easy to destroy the individual's data and provide notice of changes to the consent to the individual. There's a lot you can do with that data. And I just think we need to start focusing on individual collection.
I just want to add a comment to that, because I think I agree that's really important. And we've experienced this, many of us as researchers, but I've also experienced it collaborating with a group of nonprofits trying to work through issues of whether it's ethical to share the data they have collected for service delivery. And so in thinking through that process, we did conclude that an informed consent, through talking with our legal team and IRB, a whole bunch of folks and the agencies, that informed consent is probably the best way to do it. But there's so many challenges in implementing those from a human service delivery standpoint. So in the point of health delivery, it's a little bit more straightforward because exactly at what point what you're collecting about them, how you might want to use that. In some of these other settings, it's not quite as straightforward. And usually that informed consent is for a specific one specific use. So how can we structure those, or can we structure those in a way that allow broader use? Because if you go through, for example, the Institutional Review Board, IRB, that, your informed consent is very specific to a particular research question, or research project or initiative. So as we think about like kind of broadening this out to a variety of purposes and trying to integrate this information for multiple use cases, I think we have to think about if there are ways to go through that, still treat people, give them the consent and the opportunity to opt in or opt out, but in ways that maybe are different than the way we typically handle it.
Just add to that, it's obviously extremely important, right? If I get a referral for DPP and I need to turn around and send that referral to, or refer that patient to Gleaners or XYZ other community-based providers, it's a real challenge, right? And not just a challenge from a consenting and how do I do that sort of in a streamlined way, but it's a real challenge from sort of a patient experience perspective, right? What's it like for that patient to get referred to me from their provider to the Y for DPP and then to turn around and send them to another organization? And do they feel like they're getting the runaround and having to call 15 different people? Or is there a way to really streamline that and center the patient experience when multiple referrals to multiple entities and the feedback back to the provider is required? And what does that system look like in a way that makes it very easy and understandable for the patient and the person at the center of all this referral mechanism and data governance and sharing, right? I think also the challenge when you look at this sort of governance and setting up these systems long-term is, we know that 80% of health happens outside of the clinical setting, but the reimbursement structure is not set up for that right now, right? 80% of the funding and the reimbursement and the sustainability for this work doesn't happen outside of the clinical setting. And so how do you shift or share that power amongst sort of a system of partners and the patient at the center in order to really create sort of a streamlined, efficient way to serve the patient across multiple domains, multiple stakeholders, multiple sectors?
So to Chelsea's point, talking about how the supermajority of healthcare often happens outside the healthcare setting, where it's becoming increasingly apparent where some of our traditional laws are somewhat antiquated. You look at, for example, HIPAA. HIPAA focuses around collection of PHI by a covered entity. They are under a very strict privacy framework of what they can do with that data. However, there could be another organization that literally collects the exact same sensitive type of information that doesn't fall underneath HIPAA. And it's a very different framework. And so we need to start thinking about privacy, not only just around the type of institution that collects it, but really the type of data that's being collected, and marrying that with a consent model, to Sharon's point and Carl, that can cut across a lot of the existing legal frameworks. I talk about how if I go and have my blood pressure taken at IU Health, for example, or any other healthcare provider, that's protected health information. If my Fitbit collects my blood pressure, they're not subject to HIPAA. So we have information that is being treated incredibly differently simply by who collects it, not necessarily the type of information that it is. And that creates the disparity amongst our social determinants of health, where we can't share that data with the same level of necessity that we otherwise need because of artificial barriers that we've created. So I'll just say on that note, everybody provide comments to the proposed rule on HIPAA that deals with social determinants of health, due by May 6th to the federal government. It's a really great rule, great stuff that'll actually enable social determinants of health. So write your congressman and CMS.
And I'll add to that, and in terms of the challenges we face at MPH, this idea of consent would be a huge help for us, because it is the privacy that we always run into, that we have all these great data sources that would be great to share and combine and make these meaningful longitudinal data sets, but it just, you start running into barriers along the way. And if there was a more streamlined process where we could kind of get rid of some of these antiquated policies that might be in place through a, informed consent. I think that could be a huge step forward in expediting many of these problems or getting rid of them.
Any other, so I know we've got about 5 minutes left for our session. Any kind of concluding remarks that people want to make? Is there anything that didn't get brought up during the discussion or something you saw from the chat that you think we should highlight here or address before we conclude?
I can respond to the question about consenting against someone's will or due to a lack of education. So we deal with that on the research side all the time. So often the terminology we use is that the consent needs to be written in an 8th grade language. It also has to be translated. And that's that's the whole point of why I brought up consent as a talking point. So currently, even much of our consents are written on paper, or if it's on an iPad, it's the equivalent of paper, right? You're signing an electronic form on an iPad that you don't get a chance to read. I just did that at my dermatologist yesterday. And so why I brought that up was we need to start thinking beyond the existing technology, beyond the existing framework. And the reason we want to do that is because informed consent, appropriately done, meaning it's conscionable, meaning you're not doing it against someone's will, and that it's easy to understand. More importantly, also that it's updated, that people can change their minds at any time for any specific reason, so that there is and there is broad consent on the research side. That's a recent change in the last 2 years that we try to get broad consent for future research, but we have to start thinking about it differently than we are thinking about informed consent now. If there was a way that the state could create a portal like the MPH where we could be, you could add your projects and your uses to the state portal, and then you could direct the individuals to the state, and the state manages that. That's one possibility. There are also thousands of other possibilities. And that's the whole point. We have to think about it differently than we currently do. It takes a new paradigm on how can we enable people to share their social determinants of health for the reasons they want to share it for. And though we have needs, then we have to explain what those needs are to the individual, so they are then motivated to share the information because they see a benefit for it and society sees a benefit for it. It's not about hiding the ball. It's not about tricking them. It's not about opt-in versus opt-out. We really have to educate and create something that was really going to work for a long period of time. Informed consent is the ultimate way to share data. Every other way we do it is through a waiver or through some other method or some law allows us. Informed consent is the ultimate freedom to do that when you have the person's permission to use their data, which would then align with GDPR and the CCPA and University or State of Washington's new privacy laws. State of Indiana will have a privacy law one day. The federal government will have a privacy law in the next 5 years. I'm sure of it. So informed consent allows you to navigate all these the different laws and the different entities and whatnot. It is really the ultimate equalizer.
Yeah, and the informed part, I think, is really key. I was talking with one of my neighbors who's a real estate agent in this market that's incredibly hot right now. And he said he'll send a housing contract to somebody and through DocuSign, and they'll sign it and send it back to him within 30 seconds. And then he calls them and says, stop, I'm going to resend this to you. I want you to actually read it and understand what you're agreeing to, because once you sign this, you are legally bound to these things. People on their phones, they can sign it. They're like, well, it just said to sign it, so I signed it. And so I think, I think we have responsibility to ensure, informed consent actually happens rather than just consent. So I think you brought up a good point, Carl. And, we have to understand how to interface with people and that they really understand what they're agreeing to do. Any other final thoughts very quickly? I want to make sure we keep moving forward. All right, well, thank you all. Oh, go ahead, Chelsea, sorry.
I was just going to say, I think just continuing to echo the importance of centering the patient's experience or the individual community level opinion in this, right? That we don't keep it so institutionalized that there is not community voice or input in how this system is created, the data is governed, and what happens with it.
Excellent point. So on that note, I want to thank the panel. Fantastic job. Thank you to all of you who put your comments and questions in the chat during the session. So I will turn things over now to Darshan so we can move forward.
Thank you, Brian. Thank you, panelists. Fantastic discussion. What a great diverse kind of panel to kind of touch on a lot of different kind of aspects of these governance and data sharing challenges. Really like the conversation about the informed consent piece and everything kind of most recently, but what a great discussion. We're break time. So 11 o'clock, we will kick off with our second panel. So take 9 minutes and we'll see you guys momentarily. All right, welcome back, everyone. Hope you had a nice little break. And we're getting ready to roll into our next panel. And I'll hand it over to Shelby Cummings with LISC, the Local Initiatives Support Coalition here in Indianapolis. I get the last letter on the corporation. I always get the last C wrong. And Shelby's going to be leading our illustrious next panel here. So thank you very much.
Thanks for the opportunity. Really appreciate just the honor of being invited to get to share space with these amazing panelists, women who are leading their organizations in managing social determinants of health data, as well as really all of them are direct service providers. And so they have relationship with data sharers, which I think really is an important part of what they do and their experience that informs this a bigger data set. There are faces behind those numbers to these panelists, and it's a great informant of how they see the development and management of social determinants of health. So on the panel, we're going to hear from IU Health, Community Health Network, Eskenazi Health, FSSA, and then LISC. So what we'll start out with, when we went through the planning process with the panelists, just the passion and deep interest in doing and managing social determinants of health data well. We were thankful for the coordinators of the workshop to kind of pare it down a little bit, because there were so many thoughts and so many different directions that this panel group wanted to go. But we're really focusing this panel on identifying the resource directory information that each of us are using in the spaces where we are, really close links to themes that we just heard in the last panel, such as trust, relationship, meeting basic needs, having patients centered in the decision-making process and reflecting on their experience. And so I'm going to see some great synergy that flows from that last panel into what we're going to discuss in this panel. So we'll start out with introductions, where the panelists are going to share who they are, their organization, what resource directory platform that they're using, what capacity does their organization lend to the utilization of that platform, just some thoughts about what populations are most often providing resource information to, and then we'll go into more how has that resource helped them meet the needs of the patients and residents that they are working with. So we'll go ahead and start with IU Health.
Sorry, a little housekeeping there. I need to find the mute button. Thank you so much, Shelby. This is Nicole Sermon, and I am a Director of Community Health at IU Health, and I work along Dr. Karen Amstutz, leading work to impact social determinants of health. At IU Health, we use Aunt Bertha for our directory platform, And we've branded this tool also as IU Health Connect. So you'll hear it as Aunt Bertha or IU Health Connect, public facing platform to our patients. So at IU Health, Aunt Bertha is mostly used today by our population health team, which is the team led by my colleague, Tori Bratcher. And that team serves the patients we take financial risk. And so there is some use of Aunt Bertha throughout IU Health, throughout the system, with the most active cities being Indianapolis, Muncie, and Bloomington. Most recently, the trend of users on both the public and staff platforms has been about 1,000 users per month for the past 6 months, the peak of user access on IU Health's platform being in March of 2021 this year of about 1,200 users. So over the past year, just to give you a little bit of insight into our Aunt Bertha use, we've received close to 10,000 searches on our platform, and the most searched categories have been health, 24% of those being health, 22% of those being food related, and 21% of those being housing related, and food being more in demand now versus past quarters. And so just a quick insight to Aunt Bertha, and you'll hear this continually, I think, from those on the panel, but it provides a great opportunity for closed loop referrals to those social needs. And we continue to build awareness within IU Health about this platform and build the relationships with the CBOs to increase overall use and create confidence in that closed loop workflow. So the platform really allows us to connect patients, but we really need to do more within our healthcare system to make the platform more widely known by providers and really allow it to be embedded in there.
Great, thank you so much, Nicole. Let's go ahead and move on with Christina from Community Health Network.
Good morning, everybody. I'm Christina Graham from Community Health Network. I'm a business process analyst leading the work for our network around social determinants of health. And so we also use the Aunt Bertha platform, and we have integrated that platform as well into our electronic medical record, which we use Epic. And so what that particularly means is we screen for social determinants of health needs, actually utilizing the 12 domains from the Epic screener, and then have a hyperlink out to our branded version of, similar to IU, our branded version of Aunt Bertha, which is called Community Connections. And so we link out directly from the EMR. The population's mostly using this now. We've actually deployed a network-wide strategy around social determinants of health, which includes step one, starting to screen people, which will lead obviously to further connection to resources. So we started with really the folks that were sort of doing the work already, right? So that's your case managers and resource coordinators, various titles, but all doing similar work. And so to undergo this, what we initially started with a couple of populations. We started with case managers in the inpatient setting doing discharge planning, and incorporated, they are doing 5 domains of screening on discharge planning to integrate with their workflows, which makes sense for a discharge planning workflow. And then utilizing community connections to connect to resources that way. And then we recently underwent universal screening, which that's been a hot topic the last day or so, and universal screening in our ambulatory care settings. So primary care launched a pilot, and we worked some of those tweaks out, and then the rest of our primary care space has now implemented universal screening. And we took it a step further, and we haven't quite gotten to specialties yet, but the women's product line in our organization, which lives with a foot in both worlds, right? Specialty and primary care. And so they actually have scaled social determinants of health screening into their new intake visit with obstetric patients and launching out to community connections. And they can make referrals right there to a care coordinator that's embedded in those offices. So that's sort of how we scaled it. Utilizing Aunt Bertha, we've also had seen quite a scale up of adoption using their sort of adoption maturity model. And so we have about 5,000 users on our platform. We've done about 16,000 searches since our inception and made about 1,500 connections. So we're working to increase that adoption in various spaces, including community health, community-based organizations, so we can increase adoption. And so that's kind of where we're at on our journey.
Thank you, Christina. Deanna with Eskenazi.
Good morning, everyone. I'm Deanna Reynoso. I am a pediatrician with Eskenazi, as well as now serving medical director of social determinants of health with the Eskenazi team. And we also have implemented Aunt Bertha as our platform. And we are a little bit newer to using it. We rolled it out initially with our community health workers back in July of last year. So we still don't have a full year of rolling it out. From there in December, we rolled it out to the Sandra Eskenazi Mental Health, and shortly thereafter to all of our primary care FQHC sites. With the rollout, when we rolled out to primary care, we rolled it out to everyone who was at the site. So including our medical assistants, our nursing staff, providers, including all the social work and community health workers. With that, we also have the branded version that is Neighborhood Resources Eskenazi, and also have integrated it with the EMR with the link to make it easy to use for those in the clinical setting. We are currently in the process of looking to further roll out to our specialty and our hospital-based inpatient teams as well. We had already implemented universal screening prior to the rollout of Aunt Bertha, and really tried to coordinate both of those at the same time. So part of our reasoning for the way that we've implemented the use of Aunt Bertha is to make sure that if we're completing universal screening for the social determinants of health, that we have the capacity to give the resources for all positive screens. So it's very important for us as we are doing universal screening for social determinants of health that we aren't just screening and that we have availability. We have about 30 to 40% screening positive with the hunger vital signs for food insecurity at this time. And throughout the pandemic, that has varied, but obviously a larger need for food resources, and the realization that at that volume, if we're universally screening, we can't do a social work referral for every single one. So specifically for us, we have 57% of the use is surrounding food resources within our system, 22% housing resources, 12% utility resources, clothing and goods, gets down to smaller, and the rest for other smaller categories. So we have still a lot to do as far as the closed loop referrals. I looked at the data. It looked like we have about 40 where we actually closed the entire loop. A lot of that is that this is also newer with our community-based organizations, and until it's broadly embraced in the community, that particular feature is not nearly as utilized as our giving resources and linking resources either via text or email to patients in real time in our clinical setting. So thanks for having us today.
Thank you, Deanna. And we had a great addition to the panel with Secretary Sullivan with FSSA. Jen?
Good morning. Wow, it's so nice to see so many old friends from the last 25 years of multiple different walks of life on this call today. I couldn't be more excited to to be here on behalf of our agency. As many of you know, the Family and Social Services Administration is the state's largest agency. We operate with about a $19.3 billion budget, and our job is to help you. That's the whole point of us being here, is we are a connector to resources. And over the last 4.5 years, we've really spent a huge amount of our effort and philosophy kind of moving the big boat of this agency from being a bank to being an integrated health and human services delivery agency and a connector. And that journey has really been extraordinary. And this is the driver. So social drivers of health are the only way that we move the needle for health outcomes for Indiana. And so it's so exciting to see our health systems being part of that solution, because human services, public health, and healthcare, I think about them all as the 3-lane highway driving us to health outcomes. So that's that highway to health. I have to pronounce that really carefully as I say it out loud as a pediatrician, because we're not allowed to say bad words. But you know, these groups kind of getting together and thinking about this work collaboratively helps us really drive forward this concept that we use, which is we are a yes and organization. So yes, do this, and we're going to do this, and all of these kind of blended philosophies and communities working together will help us get better. And so what that means for the topic of today is that we are sort of platform agnostic, but let's make sure that all of the platforms help each other, because what we can't do is create an additional burden for a really fragile CBO network, our community-based organizations who are trying to help us connect people to the things that they do. And so I think where the beauty of all of this work that's happening in our healthcare systems, and thank you for the leaders that are here today for really spearheading and thinking about people, not conditions, because we really can't do that and expect to find ourselves in a different place, is that what you'll get and what you'll see from us at FSSA, and hopefully have seen through the pandemic, because we've gotten pretty good at it in the last year, is that we come behind you with this supportive network of how we connect. And so we have a layered data system. We know, and we knew 4 years ago, that we know a lot about people, but we don't know people. So we have an enterprise data warehouse that is a treasure trove for a researcher like me to find out things about folks through Medicaid data, through our enterprise data warehouse, through SNAP data, through TANF data, through mental health data, and integrating those was our first step. But then we needed to know our members a little bit better. They're your patients, our members, our neighbors, our loved ones, ourselves. And so we created the Health and Wellbeing Atlas, and I'm going to put that in the chat so you all can check it out and play with it. It is for every SNAP, TANF, and Medicaid application that we receive. We get about 120,000 of those every single month. At the end are the 10 health leads social drivers of health screening questions. And so that universal screening option that you all were talking about, we're doing it too. So we're in this business with you of looking at those domains of housing insecurity, food insecurity, safety, education. Are you looking for a job? And what are those additional things that we might help you with beyond the SNAP application that you just finished? And so we took all of that information, you know, over 500,000 data points. Think about the power of that kind of information that people have voluntarily said, we need some help and we'd like for you to help us better than you do in these fragmented ways. And have that in a map that updates every week. And it helps us generate conversations at the local level about what we really need and how we might partner together to be more efficient in getting there faster. Additionally, on top of that, the 211 partnership officially became the 8th division of FSSA last July. And we did it for this purpose, to sort of be a foundational structure of assistance in a centralized way so that federal, local, state resources could all be harnessed and utilized in a way that we could really augment them with the data that we have, the communications that we have, the finances that we have in this agency to kind of harness them forward. So those are those 3 layers of data that we start with. And the beautiful thing about that is that they all can be, with these kinds of conversations at the community level, both in the healthcare setting, in the human services delivery setting, they can all become interoperable and we can make each other better. And think about the richness of what that looks like in the future for, I'll just hypothetically kind of, you know, what Nicole and Christina and Dr. Reynosa talked about. What happens if you update as a CBO your information within Aunt Bertha and it just auto-populates and updates all of the resource databases so that everybody has the right information? And then we start to make these closed loop referrals, and it doesn't matter what your point of entry is. So it may be in one of my Division of Family Resources offices where you come in to finish out your Medicaid application, but you actually need some other help too. That may either be a warm handoff or a 211 phone call, or it may be a closed loop referral through an Aunt Bertha system or an Indiana Community Connect. And all of these things are not now just hypothetical, they are real and possible. And I think will define the future of health, human services, and public health delivery for the future of Indiana, because we have all the people at the table who care about this stuff and realize that in the long haul, not only is it the right thing to do, it's actually the cheaper thing to do too. And so we've got all kinds of things working together to make this happen. And I'll sort of close this opening segment with the beauty of the now is that there's some real interest in actually paying for it too. So a letter came out from CMS, who is our kind of main partner agency at the federal government, talking about the idea of, social drivers of health. Now the science is there. So we don't have to really contest that. We know that helping people have access to healthy food and a safe place to live and transportation and all of those things are actually going to drive health outcomes. So how do we build a service line within healthcare delivery, within Medicaid, within other payers, so that we actually pay for those things? And so moving out of pilot mode for a couple of states like us that do that, and into really this is how we drive health forward is pretty extraordinary and a great opportunity for all of us.
Thank you, Secretary Sullivan. So as introduction, I'm Shelby Cummings, Social Determinants of Health Officer with LISC, Local Initiative Support Corporation. And, all of you know who IU Health is and Community Health Network, FSSA, Eskenazi, but some of you may not be familiar with LISC. So we are a nationwide community development financial institution. We're the largest in the United States. We're focusing our efforts and investments in 38 metropolitan cities throughout the United States, as well as rural areas. And we take a comprehensive approach to investing in the social determinants in disinvested neighborhoods. So it's those communities where residents are experiencing the greatest health disparities. And most often these are communities that are communities of color, because we see that with economic conditions, we are also seeing the institutional barriers such as racism influencing those health equities. And so we partner with communities to help build a quality of life, those systems, those social determinants that have experienced deterioration over time, have experienced disinvestment, in order to elevate the opportunity for access to health, access to affordable housing, quality education, public safety. And we do that in the partnership piece, and the support element of LISC is we support communities who do this. So we implement community action plans that focus on the development. It's resident driven, it's stakeholder focused, where we do have a resident centered approach to the development and the planning of what happens in a community. So currently we're funding 7 of those quality of life plans, where we're focusing, and 90% of our investment goes into moving the development of those quality of life plans forward. And so why is LISC in the health space? Well, as you all know, and I heard it mentioned earlier, health happens outside of the clinical space. And so just the importance of community development being seen as a critical implementation partner to the data and the research that you all are doing. Now, how do we affect change in the communities to address what the data reveals? And so LISC does have some database that we collect, aggregate data related to a number of affordable housing units developed and related to community development. We do in our Bridges to Career Opportunity program, 4 of them here, and we're expanding those with recent investment from Lilly, to where we capture data, and some of it is health related, some of it is insurance utilization and that kind of thing in Salesforce. But we also convene a community of practice, because LISC is an intermediary. We fund community-based organizations. So we don't collect individual data ourselves, and we don't have our own resource referral database. But when there's an interested party in receiving services or getting information about a resource, we connect them with our community of practice, our community-based organizations. and here in Indianapolis, they are providing basic, solutions to basic needs, as well as engaging residents in the agency of the development of their community. So engaging them in community leadership, building social capital, helping with economic development there. So they have their own resources, resource directories, some of them, and so there will always be, hey, we're CBO and we really thought 211 is fantastic. Now we have kind of took some input from our partners as to what is working for them and what isn't working for them. So please know that there are outliers to what was generally shared from our community-based organizations. They have found that they have developed their own databases or their own frameworks resource, because they want to know, is it actually accessible to the resident? Do we have a relationship with that other organization? Are the service providers representative of the community that the resident is looking is representing themselves? Will they get the care? So they really know that residents are looking for these resources through relationships. So many of them have, it might be an Excel spreadsheet, it might be hosted on a community neighborhood association website. So many of them are using that. They have used the community, AuntBertha.com community resource platform that we've heard that the case managers most often use that in conjunction, like sitting with one of their residents, as compared to, hey, you go find it yourself, because they want to then filter and have their own personal knowledge of the quality of care that this person might receive in that resource, that's the information. We have received feedback that when the transition from localized 211 went to statewide expansion, there was a lot of hope that this would help meet the needs of residents in a broader way. And we've heard from our CBO leaders that that has not been the experience that they have had, that caller experience, long wait times, the accessibility of the resources that were shared, as well as the accuracy of some of the resources. For instance, if they're calling and somebody from South Bend answers the phone, that person doesn't have a knowledge of the local community that could help them kind of navigate and filter out some of those challenges. So those are some feedback that we got. While they clearly identified there were challenges with what 211 was before, they're seeing greater challenges now. One of our CBOs who has regular communication with Indiana Community Connect, they said it's a great experience, but it requires a lot of time to maintain that information and the referral relationships. And so they have the capacity to do that, but not all CBOs have the capacity for that regular interaction to make it a quality exchange with 211 and ICC. So, you know, who in our community-based organizations are using and referring patients? So we have community health workers, we have case managers, job coaches, we have resident support specialists who are working with residents who are in permanent supportive housing, community education coordinators, community builders. They're all using local directories. And then if they need to expand beyond what their local directory has in sitting with a resident, they'll go through and use Aunt Bertha or participate with 211. So how has, shared just a little bit, how has adopting newer platforms or using Aunt Bertha, they have been able to meet needs, unique needs that perhaps there isn't a resource in their local community that they're already aware of. They've been able to expand their network by using these platforms that have more information than what they have for their local communities. So, thanks so much for the introductions and where each of us are. So you can see it's a really diverse, even though we have Aunt Bertha represented, and then we have a 211 represented in Indiana Community Connect. Each of the partners and panelists are utilizing those platforms in different ways, and the amount of time that they've been engaging with it in different ways. As we planned for this, it was an interesting discussion to hear from the panelists why the healthcare providers chose Aunt Bertha. And so we'll start with that. Why did your organization choose Aunt Bertha? as your resource and your referral platform. And then we can speak with Secretary Sullivan as to why the transition to the statewide 211 system as compared to funding the local resource platform. So let's go ahead and start. Deanna, you want to share why Eskenazi chose Aunt Bertha?
Sure. We were on a process of looking at different resource directory platforms. And I think a big part of our decision had to do with some of the other health institutions in Indianapolis choosing Aunt Bertha. And for us, it made sense not to go with a different platform than some of the other institutions, for example, both community and IU, and just for being able to utilize having community-based organizations update in Aunt Bertha with, for example, community also updates it for us. And so working together across the health organizations in that sense. And then secondly, I think it was important for us to have something that was going to be easily able to be accessed in our EMR in order to be able to utilize it in the fashion that we were hoping. And so I think it would be maybe different if we were only rolling it out to social work or our community health workers. But our expectation is if a medical assistant knows that someone needs food resources or housing resources, that they have the capability to easily be trained to link into it and add that to the after visit summary, text it, email it, however the person's preference is, or as they become more and more available, do the closed loop referral. So that was a bit of our decision making as we were choosing what platform to utilize.
Great. And Christina, how about community? Why Aunt Bertha? And did you guys consider maybe with 211, did you consider Indiana Community Connect at that time?
Yeah, I think so. Community embarked on sort of a journey to not necessarily having in mind what platform to use, just understanding that the use case involved needing a resource directory that could work in a couple of different ways. One, we wanted something that could integrate into the EMR. That was essential. We wanted something that was going to be able to perform with some interoperability potentially, and also a platform that was going to allow for ongoing curation of the programs listed within the directory, and how was that information being kept up to date, and what would the resource directory's role in that be versus what would our role in that be. And so I think there was really just an overall evaluation of multiple different platforms. To be really honest, there was a lot of platforms that were evaluated in that process. And ultimately it came down to a decision that really looked at all of those factors and what could we do most easily, what organization in terms of resource directories had experience working with as an Epic shop. Epic's obviously a large EMR, so many of them had experience with that, but also the role in terms of keeping that information up to date was significant. So those were important features, but I think the final decision, I don't know that there was a hugely scientific process other than looking at all of those. Did it check all the boxes? And at that point, I believe at that point there were a couple of organizations using Aunt Bertha. So we also did a process of reaching out to those organizations and saying, hey, what's your experience been? Once you whittle it down to a few. And so spaces like Ivy Tech at the time were using Aunt Bertha. So we were able to sort of say, how did that cross-sector use look? What did you guys identify? And so when community signed on with Aunt Bertha, I know there was some attempt to collaborate within the other systems. So IU came on shortly thereafter, and Eskenazi came on shortly thereafter. And so it became sort of some synergy from the larger health systems within Central Indiana that we could at least have one singular platform that we could all sort of benefit from. So I don't know that there was, other than some of the basic requirements, you know, that kind of a gap analysis was what was done initially.
Great, that's really helpful. IU Health, Nicole, why Aunt Bertha?
Yeah,
Maybe.
very similar process. So no need to repeat exactly what's been said by Dr. Reynoso or Christina, but I think that thought process was similar along the way. You know, we knew we had a need for this. I think the closed loop referral piece was really something we were able to hone in on to help with that decision making. And at the time, the difference of what Aunt Bertha provided versus what 211 provided. I think also just knowing the other service providers and where they were heading and how we could utilize the same adopted platform. So when patient information is put into the system, even though we may not be able to see the referrals, the CBOs can. And so how can, you know, we work and make it easy with the CBOs to use this platform and coordinate for our patients who may be seeking services across our different systems.
Awesome, thank you. Now we heard Amy explain why FSSA went to the platform they have yesterday, and there's multiple resources that have been shared since then. So we will talk about understanding, you know, and I shared the community-based organizations, and many of them have their own databases. There's Community Compass that's focusing on food access that some residents will use. There is a new public safety app that will also have resources for the Near West community. So there's many different ways that residents can access resources from the community-based grassroots level. So we all see the value in the pathway we've chosen, right? Is there a way, I know that there is a desire, but is there a way that we can collaborate? So one instance that perhaps we could collaborate is we're all trying to make sure that the quality of the resource information that's shared is accurate, that it's quality, that it is actually really getting folks to resources that they're needing. So how is it that each of you are really making sure that the resource data that you're sharing is accurate? So Nicole, you want to start?
So I think Aunt Bertha does a really nice job of helping all of us as their partners get together in the Indiana area and review that CBO information. I think the narrative that they've put together from the health system standpoint is very helpful, so we can understand the quality of the resource directory information that's available, as well as some of the gaps in information that we may be able to work together to better define. I think, you know, being confident in that data and that information is accurate and being able to be shared between service providers, states, and CBOs is something that we need to make sure that we have. And I think at some time today, there's still some question related to that quality of resource directory information, not so much maybe between the partners who are using the same platform, because we are able to collaborate and talk through that, but maybe partners that are using a different platform or knowing which platform to refer patients to, thinking Aunt Bertha, thinking, you know, of the food specific platforms with Community Compass and 211.
Thanks, Nicole. Deanna and Christina, do both of your organizations have staff who are reaching out to CBOs and those referral resources in order to get accurate data as well?
Sure, I can speak to that a little bit. So a couple of things we do, just the first part of the question about keeping data, you know, up to date, is it has been because we've scaled this sort of kind of broadly across the network. We have enabled part of our trainings to demonstrate some of the functionality of the Aunt Bertha platform, which includes suggest a change. And they have Aunt Bertha then takes that and has a two-step process for ensuring that that information is accurate and what the CBOs are actually, that information is correct. We're also trying to just internally ensure that our own programs that we own as a network are claimed, have an owner, and working to just increase the maturity model within our own organization to be able to accept referrals from those for those internal parts. So the second part of that question, I think you had said, remind me of that second part of your question, Shelby, I apologize.
So you have staff who are dedicated to capturing that data. What we heard in our is that each of you have staff dedicated to improving the quality of that data.
Yeah.
Might this be a space where collaboration could happen, a centralized, person or organization or, staff between the three organizations? Might this be a way of collaborating?
Yeah, so I think that's a fantastic idea, and it sort of started as grassroots efforts, right? Initially there's the Indiana Collaborative, obviously, sponsored by Aunt Bertha, but I think there's space if we can identify other organizations that are using other platforms, we could even enhance that collaboration potentially, to your point, because we don't want to add that burden to the CBOs. And I think at least in the central Indiana region with the larger hospital facilities being on Aunt Bertha, at least we can promote that when you update it on one of our platforms, so whether it was IU that reached out or whether it was community, because we've taken this sort of divide and conquer approach within the collaborative from both the Indiana perspective and also just sort of grassroots getting together as organizations in central Indiana and trying to divide and conquer outside of the Aunt Bertha initiative. I think there's also room in that space as well to sort of have that collaboration, because we have definitely heard that we have to find ways to do this. Otherwise, the CBOs, they don't have the capacity, they don't have the ability to do that. And so we're trying to take some of that on for them. And we do have, I say staff, but it's also not as though that's their only job. It's certainly a part of other duties as assigned that are working through that. And so I think there's room on all fronts for sure.
Great. From the hearing from our CBOs and knowing how we invest in their capacity, if there are multiple platforms that they have to become a member of in order to get referrals, that's going to cost. As Chelsea Winter showed or discussed earlier, the community-based organizations, though they are providing critical care outside of a clinical setting, they don't have sustainable funding sources in order to do this. So anytime there's this additional time needed for administrative care or maintenance so that they can get quality referrals, it's cost, and there's currently no policy that actually allows them to have sustainable funding sources. So Secretary Sullivan, let's move there. That would be great. But in that vein, there has been concern about having a third-party for-profit company owning a platform, and we know that they'll have to continue to generate revenue. And what changes to that might the cost of pass on to the CBOs in order to maintain these? So the hospitals, you guys have really identified, okay, you've set aside revenue in order to maintain these platforms. CBOs are going to really be challenged with any potential for-profit activity by Aunt Bertha. So Secretary Sullivan would love to hear about how FSSA and 211 really kind of can manage some of that cost to prevent an additional cost to a CBO to participate. Where's the funding for that and their participation? And
that's a lot to cover in 3 minutes, but I will do my best. So first of all, just going back to the kind of initial question about 211 as a central resource. One, the goal here was to actually decrease administrative burden and actually free up some of our community organizations who were going about trying to fund those local coalitions through philanthropic dollars and actually take on the burden of doing that. So the state did not pay for 211 before, and now we do. So the entirety of that budget is mine. So it's a line item in the FSSA budget, and it's not going anywhere, which is, I think, to me, should give everybody a little bit of deep breath. Okay, we've got this foundational service. It's only been part of FSSA for less than a year. So, and during a pandemic, I'm not going to use those as excuses, but we had the things that we've been able to do with this incredible team, bringing the community navigators on board as state employees, giving them a home, providing those extra resources and training and all the rest. And, we also kind of part two is to maintain that community flavor, in that we have this really extraordinary advisory board that's connected to those local resources and helps us be accountable so that we don't look, in fact, we don't look like state government in 211. And in fact, 211 makes state government look more like the community. That's the whole idea of this interchange, is that we get better as the state, which I despise, but that's where it is. We get better looking like everyone else that we serve. And that's pretty extraordinary. So what the hope is that, as we absorb the financial burden, that allows our community partners to get back to what they really prefer to be doing, which is funding local initiatives, really shoring up this sometimes very fragile network of community-based organizations. And now that we know where we're going, we've got this roadmap to the future, then what we are able to do is allow that financial security to help us decrease that administrative burden on already stretched thin groups, so that they're not getting 4 phone calls from 4 different groups of people, that we take that burden on ourselves. And so whether it's a local trusted resource database, I love those. In fact, I use them in the emergency department, tacked up on the bulletin board of, I have this kid who needs this thing and I love Jane who answers the phone. Like I do that, we all do that. And that's not going to be replaced. It's just going to be augmented so that the folks that aren't like me, who don't know Jane, can find Jane too. And whether that is through this platform or that platform, let's take on the responsibility as larger groups to supplement what's happening so beautifully at the local level so that we can sustain it. So again, deduplication of resources, using every dollar and stretching it as far as we can, and not asking the people least equipped to do our work for us, let's do it ourselves. And so I think, and again, I think I put this in the chat, is that's not the future, that starts today. I think as we move into recovery mode from pandemic across all of these different organizations, that this is the time to say we were on the right track before, it's been solidified, and then let's now build it as this incredible and really Indiana unique partnership for the future. We're out in front. There's only one other state that has a centralized 211, and so I think we have the opportunity to build something that's really quite beautiful and collaborative. Again, going back to that initial philosophy of yes and.
So we've been given a couple more minutes, so I'm excited about this. So are we, and this is a question informed from having worked in a different state that had integrated care that was beyond a database platform referral sharing, though that was part of it. Are we relying on databases to create the structure for integrated care? Or is there more to do beyond just this framework that we have a way to communicate with each other? It's beyond that, right? I'd love to hear from any of you.
Well, I'll just throw out kind of the big picture, is that I have a quote that my team is really sick of the last 4.5 years, which is, data matters, stories convince. And it's this frame, the database relationship is key, but it's not sufficient. Shelby, you even talked about that relationships and stories and people are what drive us forward. And so data, helpful and absolutely necessary. We couldn't be where we are today if we didn't have that infrastructure in place, but it is just the beginning. The connections that happen between actual people and the things that they need, and then that back and forth feedback on how are we doing, right? So organizations that maybe have more of a footprint that can say, hey, you haven't quite gotten there yet, let's keep this rolling, aren't necessarily about data alone. It's about accessibility and what that means in the whole context of the story of the people in the community that we're trying to meet. Because really, change doesn't happen just by meeting people's emergency needs today. It's not, I'm hungry today, I need food. It's 12 steps before that to make sure that you have a food secure community in the first place. And that's, I think, what data drives us toward. You know, Deanna talked about, hey, our number one need is our unmet food needs. That's true across the state right now, absolutely certain. So let's get to that. We still have to fix those immediate needs. We can't let people drown in front of us, but let's go upstream and fix the next ones from drowning. And I think that data and those stories help inform that for the future.
So, this panel might have raised more questions than it answered, and intentionally so. And we were really confident and comfortable with some dissonance and going, this is our experience and this is ours, but that really looking at the challenges and benefits that exist in this space helps us to develop a pathway for a solution that's going to benefit residents and patients. And so this was intentional that we built kind of this. So how do we collaborate if we're all using different platforms and we have the same goal, we're committed to where we currently are, but how can we coordinate? And that's going to feed really well into tomorrow's panel that Greg Bloom is leading that will help us kind of envision a greater collaboration. So really appreciate what each of the panelists brought to this discussion. And there's lots of great questions in here. Alicia Baker, who represents Aunt Bertha, actually used to be one of LISC's funded partners and a great community-based organization leader and community builder, so very familiar. She has some good information there that each of you can access. So really appreciate the opportunity and looking forward to tomorrow's discussion that might bring some resolution or hope for resolution to these the issues that were brought up in today's panel.
Standing. Shelby, thank you so much for leading a fantastic panel. Just could have asked for a better kind of representation across all the various, entities who are touching these directories, across the state. So, and you led in perfectly for our workshops for tomorrow. So we've just got 10 minutes, and honestly, I'm not going to use all 10. I'm just going to use a couple minutes just to kind of quickly kind of recap, the day, and then kind of let everybody know what's coming for tomorrow, and then give everyone a few minutes back, and hopefully everyone can come back refreshed for a really, really, a really strong day of kind of rolling up your sleeves and helping us kind of get to work tomorrow. So yesterday and today we learned a ton. We learned from Indiana-based use cases. We learned from Indiana-based kind of experts in various kind of areas, from, obviously around the directories that we just talked about, to governance. We got some inspiration from some national experts. I keep going back to some of the key components of what kind of Christine was sharing, and some of the specific use cases they're really, really exciting, that I'm really excited to kind of dive into further tomorrow. But the game plan for tomorrow then is, and we mentioned how it's really imperative that we all kind of show up all 3 days, because hopefully all the information that you kind of garnered kind of yesterday and today, plus all of your experiences that you already are bringing to the Zoom, you can bring those out tomorrow as we break out into three different groups. One's going to be focused on statewide kind of challenges. One's going to be focusing specifically on local challenges. And then we have a special separate one for around a lot of these directory related kind of challenges that this panel obviously kind of focused on. We've already broken people out into those three groups, but if you think you're in the wrong group, let us know, and we can certainly do a little bit of kind of moving around, trying to keep the panel, the groups, as balanced as possible, in order to be able to make sure we get as much diversity of thought going into them. But really the game plan is tomorrow, up until about 11 o'clock, we're going to be doing these breakouts, and there's going to be a certain kind of framework that we're going to be collecting information in regards to identifying key challenges and approaches, and kind of what next steps, and kind of how to actually take and create a plan, for each of these three areas, and then do readouts, from each of the other three groups back to the broader group, and then identify where can these plans then kind of live kind of going forward to make sure that this conversation doesn't stop at noon tomorrow. So with that, thank you again for all your wonderful participation. I'm pretty sure if we take this chat and we put it into Word, it's like 30, 40 pages. There's a lot of great conversation going on here. And that's really what we wanted. So I look forward to seeing you all at 9 a.m. tomorrow, unless Sarah, Peter, Emily, and Matt, others. Did I forget anything?
No, just big thank you to all the panelists and all the engagement in the chat. It's been really awesome.
Here, here. Thank you.
Put on
all.
your thinking caps for tomorrow for the solutions and the action plans. I think the hard questions have been asked and now we need to work on that action plan. So a little preview.
Okay. All right, everyone. Have a great night. Thanks again.